So I'm talking about radiation damage in genes. As a head and neck cancer surgeon, I rely on radiotherapy to complete the treatment. We cannot often do surgery with just, we cannot treat cancer with just surgery alone, and we need radiotherapy. But during the course of my career, I've become very aware of the huge number of complications you get, not just with surgery, but with radiotherapy. Okay, and basically, radiation damage is due to extreme scarring. It's part of the whole process. And again, we're talking with our French colleagues again. This is a picture of Sylvie Delanian, who's a radiotherapist in Paris. And she said, well, the problems in the head and neck are no different to the fibrotic damage you get with radiation in the lungs, the liver, and other tissues. And this is the principal cause. Now, the trouble is that, you know, like my patients here, and a lot of people, radiotherapy causes damage that affects the quality of life of our survivors, the survivorship. And in head and neck cancer, because of human papillomavirus, our patients are getting even younger, and so they're going to spend a lot of their time when their survivorship becomes paramount. So radiation damage can cause speech problems. Many people suffer from this, and it's really bad if you can't be understood over the telephone. Your quality of life nosedives at that point. It causes swallowing problems, and if you have difficulty swallowing liquids, again, it nosedives. And also, you may be dependent on having a feeding tube. You may not be able to open your mouth properly because of the fibrosis in the muscle, the scarring, and it makes it obviously very difficult to eat. It also makes it difficult to keep an eye on the patient's tumour because, of course, we need to get inside the mouth and we can't. The thing that I become involved in is because it's a surgical complication, is osteoradionecrosis. Now, it affects about 5% of patients after radiotherapy. And it's this fibrotic process literally rots the jaws, and there are varying degrees of this. Now, this is actually Derrick's here. This is his radiograph. And the problem is here, is just around here, there's a very grey-black area, and that's his area of osteoradionecrosis. So, Derrick, if you'd like to kind of take centre stage now for a second. Derrick's been a patient of mine for a number of years. He first started his treatment in 2001 for a tonsillar carcinoma on the right side, and he developed recurrence, and he had further treatment for which he had both surgery and radiotherapy. But just tell us about the complications, Derrick.
Well, the complications with radiotherapy started when I was walking along the road one day and I had a crack and part of my bone came out, and I realised that, I actually pulled it out, I realised I had osteoradionecrosis, so I went into hyperbaric chambers for about 40 sessions. They helped for a while, and luckily a few years later I bumped into Andrew, who helped me enormously with some drugs which I'm sure you'll expand on, Andrew. But I went through a period where I've had my osteoradionecrosis. I've still got it, but it's kind of held at bay at the moment, as it were.
Yeah. I mean, I think, you know, we can treat osteoradionecrosis with drug treatment. And one of the ideas between NFORC is we can identify perhaps people who might need this treatment before they develop their osteoradionecrosis, because prevention, of course, is better than cure. That's great, Derrick, on that intervention. Derrick's a dear friend. I'm very sorry to say that Derrick has secondaries in his lung, which he's really stopped treatment for because the chemotherapy was so bad. And I think it's fantastic and courageous for him to come and talk to us today. Many thanks. It's quite an emotional moment, that, I say. You get to know your patients very well. So this is actually, it's a very similar X-ray to Margaret's case. Now, Margaret also had a tonsillar carcinoma treated with radiotherapy. She didn't really require any surgery until she developed her osteoradionecrosis. Now, if you look at Margaret's case here, there's a huge fracture here. And this is the problem here. You get rotting of the bone so much, it fractures, and that can be very painful. And in most cases, we therefore have to reconstruct. So Margaret, you take centre stage and tell us how it developed for you.
Well, I've never had any illness before. I didn't know very much about cancer. And when this happened, I just said, well, you know what to do. I don't know what to do. You tell me. So I had the 6 weeks of radiotherapy, which I went through with no problem. But at the time, I was a much bigger lady. I was a size 24. So I had lots of flesh to eat off for quite some time. I had no problem with the treatment at all. And I had it all clear after the 6 months. And then 2 years later, Mr. Lyons had been very carefully looking after me every couple of months, and suddenly the jaw just snapped. And I went in for reconstruction surgery, which was something like 9.5 hour operation. I had no problem with that whatsoever, and I've had no pain right from the beginning to now.
Okay.
None whatsoever.
That's very, very selective for which patients I ask to come along. Just to ask both of you, I mean, there's in America now, there's much more use of robotic surgery for tonsillar carcinoma. Do you think if we could tell you what genes you had and we could give you a risk, it's a silly question really, because I think I know the answer, would that might affect your decision on what treatment you had?
Certainly would have with me. I wouldn't have gone through this treatment and the hell that it's produced afterwards, you know. So definitely not.
I'm not sure, Margaret, you think it's...
Well, I didn't have a choice. If I had a choice knowing what I know now, I'd have probably gone for surgery. But what is done is done.
Okay, well, you're a very good patient. Okay, well, thanks very much, guys. Thanks again. I'll just, after those, very poor show after those following these two people. Anyway, do my best. So this is just the surgery for osteoradionecrosis, and this patient's actually asleep at the very moment. His operation hasn't finished. I came today. This is resecting the large area of necrotic tissue that the osteoradionecrosis caused. He'll end up something like this, but this patient is actually literally having his operation finishing off at this moment. Now, when I looked at the fact that you could genetically predict who was going to get osteoradionecrosis after the lung radiotherapy, does it apply to the jaws? And it did. There's a gene that if you have this gene, a double dose, you're 6 times as likely to develop osteoradionecrosis, and if you have a single dose, you're 3 times as likely to develop osteoradionecrosis. Now, there are other genes. And are there other genes out there? The way to look at it, I think, in the first case is look at swallowing, because 30% of people have bad swallowing after radiotherapy, and so therefore there's a much greater pool of patients you can look at. And therefore, we're going to do this study with 100 patients who have good swallowing and 100 patients who have bad swallowing, and we're going to look, don't worry about the figures really there, we're going to look at 750,000 different genes. The idea is that if there are really strong genes that are causing the effect, we will find them with that small sample of patients. And I'm very grateful for Liam for the fact that he's helped me get this study off the ground, and of course NFORC. So, can we predict who will do badly with radiotherapy by genetic analysis? Maybe in the future with the help of NFORC. Perhaps surgery, robotic surgery, wasn't really online in Derrick and Margaret's times. We can use that instead in certain instances. And we're going to be developing with NFORC the increased use of antifibrotic drugs. That I was very, fortunately we managed to stop Derrick Lucy having any further complications. So thank you very much, gentlemen, ladies and gentlemen. That's it.